Thank you, Dr. Mahipal, for including me in your course. And I would rapidly run you through refractive surface ablation and all the options which are feasible in this modality of treatment. We have come to understand that there has been a lot of revamping and readdressing of the protocols, and now refractive surface ablations are better understood. There is a greater precision in our decision taking, and we have refined the limitations which are inherent. In other words, we have a more stable platform to work on. There are certain distinct points which are differentiating and favorable for surface ablation is the biomechanical advantage which comes in the surface ablative procedures. We all know that with the meniscus flaps, there's a lot of cutting of the peripheral corneal fibers, which is integral for the stability of the cornea, and there's a biomechanical compromise with these. Whereas the surface ablation is like a surface scrape, and there is just the epithelium which is removed, and inherent biomechanical stability is augured. Going further on, the understanding now is that whenever you treat the surface, there is an exaggerated inflammatory response. So the best way to do a good surface ablation is to go for a smooth surface, which is the first crusader. The next challenge is the wound modulation. If we modulate the wound well, then the haze component is again addressed. So it's important that we limit treatments to mild to moderate, that is up to max, up to 6 diopters of myopia. We do not treat more than 80 microns of ablations, and always avoid treating on a smaller optic zone, because we need to know that surface ablations are essentially being done in thinner corneas. So you should not treat a thin cornea. You should not leave less residual lead, because you are likely to end up with iatrogenic ectasia in one odd situation. This is a thin cornea with a 465 micron, a typical symmetric bow tie, and with, because of the astigmatism, elevated points. But this is the ideal case for doing a surface ablation. This is a very small eye, wherein I have used a microkeratome much earlier on, in my about a decade or more than a decade back, when I've had this kind of an inadequate flap. Presently, these small eyes, I would definitely do a surface ablation. Or now, if you've had an inadequate flap, secondarily treat it with surface ablative option. If you have a vertical breakthrough, if you have erroneously done intralace in these eyes, then you have a buttonhole in this and in the flap, and you can see. These are situations which primarily should have been done as a surface ablation, or now as a secondary option, you go ahead and do a surface ablation. These are any number of complications which could occur with a microkeratome, and these are situations now we would know if it's a flat cornea, it's a steep cornea. These are areas where you would veer away from doing a microkeratome procedures and do a surface ablation. Or if you have had a complication, you could secondarily go ahead and do a surface ablation, and with the plan, a post-op regimen, you would definitely avoid the haze components which were known earlier on. This was another case wherein I had promised my patient to do a femtosecond laser flap. It was a very shallow socket, very prominent bony ridges, and you could see that multiple times I'm not ready to give up that I would not be able to do this intralace at this same setting. But there is a time when we need to realize that there are available good options which are safe for the patient, and I explained to the patient and treated him with the surface ablation. So essentially I would like you to all understand that surface ablation, where it stands, is a very good option. Again, this was another patient who had a residual refractive error post-multifocal IOL implant. Because he had a thinner cornea and dry eye issues, I advised that we do a surface ablation to fine-tune the residual refractive error. Again, if there's a decentered treatment, you could do any of these options with a topo-guided treatment and treat these patients. Again, as far as the different modalities of treatment which are available with refractive surface ablation, these are, one, either you could do a LASIK where you use alcohol, 20% alcohol, and expose it for 20 seconds, and the loosened epithelium gets lifted off. Or you can do an epi-LASIK where you use a plastic separator to bring about a clear-cut separation between the basement membrane and the Bowman's membrane, and remove the flap and treat it. Or you could do a wavelength PPK mode, wherein with the trans-epithelial PRK, you are able to remove that 50 micron of epithelium. Go ahead, do a laser ablation, place mitomycin C of 0.02% for 30 seconds, which is how I would advise, and then place a bandage contact lens. As far as the nomograms are concerned, with a surface ablation, you need to add a 0.5 to the refractive correction. To address the pain, which is the bugbear with surface ablation, 1. You should use ice packs for 15 minutes before doing the procedure. You should use chilled BSS before starting the ablation. And following the treatment, you should place a bandaged contact lens which allows epithelium to regrow, re-epithelialize. The patient covered with painkillers is fairly happy by the end of the day. Again, to address pain, as I earlier suggested, after doing the ablation, you place mitomycin C for soaked in a pleasure to 0.202% for 30 seconds and then copiously wash it off and keep them on topical steroid drops in a tapered regime for 3 months. We start at 6 times BD to 4 times twice for 2 months and keep vitamin C, which is an antioxidant, on a BD dosage for 6 weeks. And I've never had a single situation of haze in any of my operated patients. This was another patient which was treated elsewhere. But of course he had gone wrong, that he had been on steroid drops barely for a month and came back with this amount of residual haze. One is you could retreat them with steroids if they are coming very shortly after the primary procedure, or else you should scrape the epithelium, debride the epithelium, place mitomycin C and place the contact lens on top, and much of the haze disappears and the topography gets regularized. Stromal incursion was a major bugbear with the epirasic procedure, which I think has largely been given now because the separator goes in deeper into the stroma and creates a stromal incursion as such, where you need to abort the procedure. But now we have this wonderful option of doing a transepithelial PRK, wherein once the topography regularizes, the refractive error stabilizes, you could go ahead and retreat these eyes. Moving further on, there are new horizons which have opened up for incorporating surface ablation, the different protocols. One, you could do a surface ablation and topographic neutralization in a contrastic AC, combining it with cross-linking, which we started doing. And there are n number of indications where you are regularizing the cornea and topo-guided treatment. I'm sure some of the audience have already been there. I'm just showing 1 or 2 examples again. This is again a patient who came in with some amount of hyperopic residual following an initial myopic correction. And I'm going to be quite brief about how we manage it. Is basically if there is an asphericity change which has been incorporated, then you need to bring about some amount of defocus correction, that is, incorporate some amount of myopic correction to compensate for the asphericity change you have done, and incorporate that 0.5 for the nomogram. As you can see, as Dr. Rohit had alluded, first you bring down all the refractive volumes in the modified column to 0, and then the Zernicke's polynomials tell us that how we go ahead and incorporate at 0.7 to compensate for the asphericity change, then that 0.5 for the surface ablation. And this is how the topography looked with the plano correction. Again, this was another patient who had a mild myopic astigmatism primarily, and she came back after a Xioptics treatment with a 1.5 with a -3 cylinder. This was far and unexpected, and you can see it was a significantly decentered treatment. You can see the red hot spot where you can see there's been steepening, and on the opposite axis there's been flattening of the cornea. So what we did here is, again, we regularized the cornea by a surface ablative option called the topo-guided treatment, and this is how symmetric the cornea became. The patient did have the residual refractive error, but we did a second sitting of wavefront guided treatment. The patient ended up with an uncorrected visual acuity of 6/9 and was happy with the vision. Moving further on, this is a case of a 30-year-old with a form frustrate keratoconus, but he had a corneal thickness of 454. So this here, we decided that we are only going to play around with the Q value so that would regularize the cornea, make it a more neutral cornea. And you can see at the difference map how the decentered cone became more centered. And if you look at the higher order aberrations, there is a significant reduction in the higher order and the lower order aberration and the spherical aberration. And the final end result was a more stable cornea. This was, however, combined with a C3R in the same sitting. Again, these are another 2 examples of a topo-guided PRK, wherein you can see this was a decentered cone, which was there, which was regularized, and you have a more centered cone on the sagittal curvature map. Again, another very significantly decentered cone in this eye, the sagittal curvature map, wherein all we've done in these eyes is not played around with the asphericity, the Q value, but corrected the refractive correction just up about 30 to 40 micron and regularized the cornea and improved the quality of the vision. I could go on and on about the various modalities, how we could introduce surface ablation as a major protocol in our refractive surgery armamentarium. But I would definitely like you to go back to the take-home message. The surface ablation in any format is definitely a very reliable platform to work on. Thank you.